Hello, good afternoon, doctors. Welcome to you. Welcome. We extend a warm welcome to you on this webinar, Influenza and Prevention, sponsored by HITRO. HITRO Healthcare, as you all know, is an innovative pharmaceutical company with 30 years of excellence and 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and presence in 126 plus countries. HITRO has got 21,000 employees globally, and we are amongst the largest manufacturers of ARVs, APIs, and FDFs in the world. HITRO Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India and with wide range of products encompassing multiple specialties. Pioneering in quality and innovation, we have a distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, HITRO Healthcare provided products like Fluvir, Favipiravir, and Covir, Remdesivir, that is, for which there was an award of Pharma Excellence for COVID drugs awarded to HITRO Healthcare in August 2020. Now, for influenza and its prevention, we know prevention is very important in influenza, especially in children. And although there are many papers and guidelines on use of oseltamivir in prevention of influenza, we always like to have our own doctor's experience. For that, we have got two eminent speakers today, Dr. Mahendra Patel and Dr. Murlidhar Mahajan. Welcome, sir. Welcome, Dr. Mahendra. Welcome, Dr. Murlidhar.
Thank you.
Dr. Mahendra Patel is, sir, is MBBS MD DCH, senior pediatrician from Goregaon, Mumbai. He is in practice for past 30 years. Sir did his MBBS from GS Medical College and KM Hospital and MD from Sai Hospital.
So,
Dr. Patel holds a diploma in mother and child health and has done certification courses in pediatric asthma, pediatric neurology, and nutrition. He has been associated with various IIP and IMA activities and has long been associated with JME and past president of JME. Dr. Patel is the secretary of Medico Music Circle and Goregaon Pediatric Forum for past 12 years. Welcome, Dr. Patel. Dr. Mahajan is MBBS from GS Medical College, MTDCH from GMC and DNB National Board of Examination, MNAMS and Postgraduate Program in Pediatric Nutrition from Denver University. Sir is consultant in Jupiter Multi-Specialty Thane, Assistant Professor Genetic Division, SKM Hospital, Mumbai, and has presented more than 150 papers at national and international conference. Dr. Mahajan has delivered more than 200 talks at various CMN conference, organizing secretary for Mahapedicon, MBCon, and KMCon, has conducted webinars which is attended by PG doctors, nurses, and pediatricians on top topics like vaccinology, immunology, infectious disease, breastfeeding, etc. Welcome, Dr. Murlidhar Mahajan. And I hand over the session to Dr. Mahendra for further deliberations.
good afternoon, everybody.
Sir, you can start sharing. You start sharing.
Yeah, 1 minute. My computer camera is not working properly. Okay. So this is I'm logging through mobile of the other phone. I'll just show my face and then switch off.
Oh, no problem, sir. No problem. No problem.
I was not well for few days. I had fever and this thing.
Yeah.
Slightly recovered today itself.
Good.
So, thoda voice and cold issue is there.
Problem,
So
sir.
please
No
bear.
problem. Yes, sir. No problem at all, sir.
Just give me a second. Yeah.
Yes.
Hello, can you hear me?
Yes.
Good afternoon, everybody.
December and Jan. This is the peak flu season. And we are hearing of a lot about the Chinese virus, metapneumovirus, and to a great extent, mycoplasma pneumonia. A coincidence that it is having my initials only, Mahendra Patel, so metapneumonia and mycoplasma. So during this Chinese invasion, sort of, why are we talking of influenza? Well, we should remember that metapneumovirus, the Chinese virus, which is being talked about nowadays, since the last month, it's not a new virus. It has been in circulation for quite some time, maybe decades. So we should not worry much about it. So the focus is changing from flu to the metapneumonia. In fact, flu is a greater problem, a bigger problem, and we should not change our focus from influenza, which is a yearly occurrence and it causes a lot of morbidity and mortality. Certain aspects we'll go through. Many of us must be already knowing many things about influenza and diagnosis and the treatment part, but just a revisit and to know certain things which we don't know and to share our experience. What is influenza? Now, the influenza is caused by influenza virus. Now, this virus belongs to the RNA group and as we learned in microbiology, orthomixo group. And it's a single-stranded RNA. It is a sudden onset and predominantly causes respiratory symptoms with moderate to high degree of fever. But what we don't know, and which of course, luckily we do not see commonly, that it causes lot of complications, non-respiratory complications also, we should be aware about it. Now, basically, there are three types of viruses which are there, that is A, B, and C. Now, the most important among them is the A and B, and in order of priority, we can say that A is the most common and the most dangerous type of the virus. Now, A is very important because it causes frequent epidemics due to minor antigenic variations, and sometimes it causes periodic pandemics also. When the influenza B viruses, it infects only the humans and it causes local epidemics. C usually causes mild respiratory illnesses, infects human and swine. The currently commonly circulating types are the H1N1 and H3N6. We should remember that till date, four major epidemics have occurred after 1900. That is in the year around 1918, then around 1957, 1968, and the lastly 2009, the recent epidemic which we had. In fact, 1918 was a very major epidemic and it caused almost 5 million, 50 million deaths. That's about 5 crore deaths. Now, regarding the structure of the influenza virus, as you see, it's a very beautiful looking flower-shaped virus. What we see is certain projection flowery structures which are there, the purple ones and the yellow ones which we are seeing. The purple ones which are there are the heme protein, and the yellow ones which are there are the neuraminidase. So HA refers to heme and N, NA refers to the neuraminidase. For example, when we say H1N1, so H refers to the heme agglutinin part and the N refers to the neuraminidase part. The heme agglutinin across various influenza viruses, there are almost 18 types, and the neuraminidase are almost 11 parts. So basically, a combination of this H and the N can give rise to multiple types of viruses with minor antigenic variations and sometimes major antigenic variations which causes epidemic. To give an example, when we say H1N1, it means that the type 1 heme agglutinin and type 1 neuraminidase. When we say H5N1 means the fifth type of heme agglutinin and first type of neuraminidase. That is regarding the nomenclature. And moving on. Now, what is this antigenic shift and antigenic drift? Now, regarding the nomenclature, which is whenever the influenza particular virus, for example, if we have seen in the vaccine, the nomenclature depends upon where the antigenic variation was first isolated, that is the city name, then the year of isolation, and the number which has been given to it. For example, the currently H1N1, when we say Victoria, means isolated in Victoria 2011, and the variation number which has been given to it. Now, we should remember in this that certain virus strains are more common in birds and animals. For example, H5N1, which is avian flu, and the other type of avian flu is H7N9. This avian, when it crosses over to the human beings or from animal host to the human host, that is the time they are very dangerous, particularly in human beings and a human population which are not exposed and who do not have immunity. And that is the time which causes lot of epidemics and endemics. Now the concept of antigenic shift and what is antigenic drift. Now, as we know, the influenza viruses, they constantly keep on changing themselves, keep on reinventing themselves in order to survive. Basically, Darwin's theory, as we know, survival of the fittest. So these viruses are lot smarter than what we think. They are always ek kadam aage. So when there is a minor variations which are present, and these variations are there throughout the year, this minor variations is called as the antigenic drift, and it causes certain small endemic. While the antigenic shift is a phenomena when there is a major variation in the antigen and the ultimately resulting into a novel new influenza strain. And this antigenic shift mechanism is responsible for causing lot of epidemics and pandemics also. Now, in this antigenic shift mechanism, two words we should remember that is called as reassortment and something called as the adaptation phenomenon. Reassortment is basically when 3 or 4 viruses they simultaneously infect a particular host. So that is called as a reassortment. While the adaptation mechanism is when along with single or multiple strains, the non-human host viruses, for example, avian or other mammalian viruses, they enter into the human host. For example, the avian influenza. So, antigenic shift is a major problem for humans. Now, this is a brief stepwise to know what is the life cycle of an influenza virus. As we had already said, it contains surface proteins, the hemagglutinin and the neuraminidase. Now, the hemagglutinin will we'll just go back to the structure to see. Now, the hemagglutinin, this is responsible for attaching to the host cell, to the sialic acid residue. And once it attaches, the virus enters into the cell and it causes lysis and multiplication. And the yellow one which we are seeing is the hemagglutinin, the neuraminidase, and this is responsible for exiting of the newly formed multiple viruses units from the cell. So, for practical purposes, the H is responsible for attachment and the N is responsible for exiting from the host cells once the virus replication occurs. And this occurs through the M2 ion channel entry and the 8 strands of RNA which are there, which help in the multiplication process. So the H is responsible for binding to the sialic acid receptors, and these are particularly found in the respiratory tract epithelial cells. So respiratory tract epithelial cells are the ciliated columnar cells. And once the entry is there, the cilia are destroyed, the mucus production is also affected, and ultimately there is a lysis of the cell. So this process occurs in the first 72 hours. The first 72 hours are very crucial because the multiplication process is very fast in those 3 days, and later on the speed becomes less. So this is very important from the treatment point of view. So whenever we have to treat in a suspected case or immunocompromised, the first 72 hours are very crucial. So if you are highly suspecting it or immunocompromised or during pandemic, the drug has to be started in the first 72 hours. That is the important point. The virus is transported into the cell and ultimately there is a viral replication, and through neuraminidase there is the release of the budding viruses. The virus particles then move on to infect the other cells. Regarding the incubation period is usually 1 day prior to the infection to up to 5 to 7 days after the infection. and it is predominantly spread by respiratory droplets, but through fomites and aerosols also it spreads a lot. In children, we should remember the multiplication of the virus is very fast. They have a very high viral load and they spread the virus for a longer period as compared to the adults. Prevalence, as we told, very high prevalence rate is there, and worldwide annual epidemics are estimated to result into 3 to 5 million cases and severe illness and about 2 to 5 lakh deaths. Season in India, particularly the rainy post-rainy season, July, August, and during December to February, now that is currently. Transmission can occur up to 6 feet away through droplets, and most healthy adults may be able to infect other people beginning 1 day per annum up to 5 to 7 days. It has been told children pass the virus for longer than 7 days. How to diagnose flu? If you see the signs and symptoms, they are more or less comparable to the other respiratory viruses which are there, such as adeno, rhino, parainfluenza, metapneumovirus, and the others. The symptoms are usually fever, headache, body ache, malaise, fatigue, sore throat, myalgia. These are the usual ones. However, in children, particularly 2 years of age, we should remember that GI symptoms, that is diarrhea, vomiting, and abdominal pain, is the usual presentation, and particularly with H1N1 influenza virus. There is a comparison with the other infections such as COVID-19 and the other acute respiratory infections. We should remember one thing is that this has a tendency, influenza has a tendency predominantly of respiratory tract infection and respiratory symptoms. But otitis media is also very common, about 25 to 30% of people land up with severe otitis media GI symptoms. But many times what is forgot is that it can cause a lot of extra respiratory, non-respiratory signs and symptoms starting from head to toe. It can cause encephalitis, it can cause Guillain-Barré syndrome, it can cause renal complications, rhabdomyolysis, and the other complications. So, the other aspects also should be kept in mind. Regarding the management part, we should remember is if clinically suspecting flu, we should not wait till the report is available. On highly clinical suspicion and particularly immunocompromised and children less than 2 years of age, the drug treatment should be started within 72 hours if the clinical suspicion is high, because early the treatment, the better is the response. Regarding the diagnosis, the laboratory diagnosis, the rapid tests which are there have a high false negativity. They are not very recommended tests for the diagnosis of flu. The recommended and the gold standard is RT-PCR and to some extent fluorescent antibody testing. So RT-PCR testing is the gold standard. We should not rely on the commonly available rapid test. Treatment of influenza, symptomatic treatment initially is for hydration, and most important is the antiviral drug, that is oseltamivir. The details of which Dr. Mahajan will tell us now further. Dr. Murli, you can take over.
Okay, sir. So you can stop sharing. I will share Dr. Mahajan's slides. Dr. Patel, you can stop sharing. Yeah. Dr. Mahajan.
Thank you, Dr. Mahendra Patel. Uh, it is quite interesting to know and how nicely Dr. Mahendra Patel has summarized the entire spectrum of presentation of flu in clinical practice as well as swine flu. He has rightly mentioned few things which are very, very important. Uh, that the most of the time these illnesses will mimic most of the common occurring diseases. Respiratory symptoms are common, but however, GI symptoms, extra GI symptoms like CNS, drowsiness, rarely coming with Guillain-Barré syndrome, myelitis, or multisystemic syndromes are also very common. Dr. Mahendra Patel has very nicely summarized about the antigenic shift and drift, which is very important because, as we know, we are getting to see flu so often. The point which is very highly recommended is that we have two seasons for flu, which we know that one is in rainy season, which is very, very peak. Like all of us, a pediatrician, have seen huge number of flu cases in this rainy season. So many times what we do, we recommend them to take a vaccine in summer season prior to rainy to prevent the child suffering from severe flu, bronchiolitis, pneumonia, or other complication. The second season has just started. Uh, what Dr. Mahendra is suffering is also flu, and he was not well for 3 4 days. And I think we are also getting to see the same kind of disease now also. We are seeing many cases of flu coming to our OPD practice, and it is very vital to know how we differentiate between common flu uh, from this COVID-19 or HMPV, what Sir has told us. So let us try and understand how we are going to approach different kind of cases in our OPD. The first and foremost thing, what has been mentioned is that when we see diagnosed flu, the treatment ideally should start in first 48 hours. The problem is that most of the time the child will not present to us in first 48 hours. So how do we go about it then? Uh, there is one small talk which I'm supposed to talk also about fluvid, oseltamivir, sorry, which is very important in our OPD practice because we are using it very frequently, liberally, because they are clinically strong cases of flu. As we know, oseltamivir is a neuroaminidase inhibitor. As Dr. Mahendra has also said, there are two kind of glycoprotein. One is heme agglutinin, second one is neuraminidase. So as we know, heme agglutinin will help in attachment of the virus to the cell, and neuraminidase will help in replication of viral and release of this virus from the patient. So basically, neuraminidase will help in replication and release of the virus and affecting the another virus. So if you stop the replication of virus, in the cell or prevent it from attaching to other cell. So then our job is complete. So oseltamivir is a kind of medication which is used as a prevention of flu with the help of mechanism of neuroamidase inhibitor. Uh, we are going to use it in a large number of patients because it is very, very helpful in our clinical practice. Today, I think I will get to this few slides and these things which are very important to us. 13-month-old child who presented in OPD with chief complaint of fever, cough, cold, and persistent fever of 5 days. We knew that this is an acute viral infection with high fever, and the child has presented to us with extreme fever, cough, breathlessness was also present when he was presented to us. Child was very sick on consulting, and there are no history of cardiac disease. I also saw a few cases last week also, this week and last week, twins coming to us with long-standing cold, running nose, which is not going only, cough, which is not subsiding. There is mild breathlessness, not much, but excessive irritability. So usually what happens is 13-month, 15-month-old child, when they are not well, the first clinical symptom which strikes to us is an irritability. They start becoming very irritable, stop excessive crying, stop feeding. The weight loss is very evident. They stop taking oral intake of liquid, including water, and they present to us with dehydration. This is very common scenario in our OPD practice. So when we see such child which is toxic is because of fever, febrile illness. He's dehydrated because he's not drinking enough of fluids. He's refusing to take any solids also. He's getting irritable. And many times this bronchospasm also can cause mild hypoxemia and irritability. And then child will become more irritable and refuse to take. And in such cases, we see X-ray which is suggest a bilateral diffuse haziness. So we know that there is bilateral haziness, something like interstitial pneumonia, viral bronchiolitis. And one more point which we see in OPD practice is that sometimes these kids who was on bottle feeding tend to take milk when lying down or sleeping position. And because of this, they may also get right upper zone haziness also. So these were couple of almost say 5 to 7 cases which I saw in last week. Classical below 2 years of age. That is one important presentation. Presenting with most of the time respiratory, as Dr. Mahendra Patel has also suggested, GI symptom. There is a spurt of GI symptoms coming to our OPD sometimes, and you would see them 8 to 10 coming to patients directly come with vomiting, abdominal pain, loose motions, vomiting. So this is one spectrum of condition when the GI symptoms are common. So these are the twins and different kind of cases who came to us in the OPD. They presented to me with crankiness, signs of hyper inflation of the chest. Wheezing was present on clinical examination. Respiratory rate was slightly elevated. Next one. Yeah. So the impression is very standard. This is a lower respiratory tract infection with respiratory distress and dehydration. So basically, they were classical cases of LRTI. Either it is wheezy bronchitis, bronchiolitis, H1N1 causing pneumonia, either could be mycoplasma pneumonia, or if the child has a light upper zone pneumonia, then it may be, aspiration pneumonia. Few of them, I would say just one of this out of 7, 8 patient was admitted, hospitalized and started on antibiotics and given IV fluids. Rest of these cases, when they present to us, starting on the day one, I start them on Fluvir. As Dr. Patel has Mahendra Patel has very rightly said, the Fluvir has to start within first 48 to 72 hours. But many times the time is lost because they present to us late. They also start self-medication of paracetamol, decongestant at home. They give steam and they would say that let us wait for 3, 4 days and then they will visit pediatrician. So the crucial time is lapsed. But however, when we start using oseltamivir, the clinical response is extremely good. As we know, oseltamivir gives excellent response in first 40 to 72 hours after starting therapy. Many times we could see some slight, side effect to oseltamivir, that is nausea, vomiting, skin rashes. I have seen couple of children who presented with skin rashes, but it is very difficult to mention whether the skin rash is because of viral infection which is ongoing or because of oseltamivir. But whatever said and done, there was no severe Steven Johnson syndrome, or neither there was severe skin allergy, toxic epidermal necrolysis, and all of these patients responded very nicely to simple antihistaminic and local calamine lotion or local soothing lotion. So all this almost 8 to 10 patients presented to us. Only one was admitted in OPD, sorry, hospitalization. And he was after hospitalization, he was started on amoxiclavulinic acid, ceftriaxone, and everything was added. And basically, the child has responded only after additional of fluid because it was not a bacterial infection. So initially on OPD basis, what had happened, he was started on augmentin or different kind of amoxiclavulinic acid by gentle family physician. Secondly, when he was hospitalized, he was started on ceftriaxone. But however, the fever was not responding only. But the clinical symptoms were very classical of flu infection. So when I started him on oseltamivir, the child responded dramatically. One more point which we has to be known with oseltamivir treatment is many times there could be some confusion, slight CNS side effect of oseltamivir. I haven't seen so many of them, but yes, it is mentioned that sometimes they can got delirium, confusion, and maybe some central nervous system side effects are there. That has to be also kept under observation. So as a pediatrician, we need to see that when we start on oseltamivir, first of all, observe for any untoward side effect of oseltamivir, including skin, GI, and CNS. Next, please. Yeah. So this child was discharged only after a febrile period was started after immediately after starting oseltamivir. So we knew that the child has responded so beautiful, and then the reports came, as Dr. Mahendra has very rightly said. The preliminary tests are not going to give any conclusion. So final thing is always a PCR test. Many times the parents are not affording, or maybe on OPD basis, of course, they are not interested in doing this test. Preferably, they want some treatment rather than investigations. And collection of sample is very crucial for H1N1, throat swab, and nasopharyngeal swab. So all these challenges which we face in OPD, we try and see that clinically as much as possible, we try and pick up the diagnosis and start them on early treatment. So we know that there is epidemiology of respiratory infection, influenza, diphtheria, meningococcal, parainfluenza, H1N1. These are all epidemiologically important. There are two peak season, as I rightly said, July, August, or any season when the child, all the children go to school, uh, been at home for 2 months, and suddenly the rainy season starts. The viral replication is very high, the viral load is high, and then suddenly there is a bout of influenza illnesses in July, August, September, and then second one is in winter season. Next one. Yeah. So the respiratory infection, we know we divide them into two things. Like even we explain the parents that it is a upper respiratory infection versus lower respiratory infection. And we know that in upper respiratory infection is something which is just up to trachea, below larynx, which is rhinitis, rhinorrhea, sneezing, or maybe purulent discharge from the nose, mild postnatal discharge, so dry cough occasionally. These are all symptoms of upper respiratory infection. But moment that infection goes down to respiratory tract and bronchis and bronchus and alveolus and lungs, then it is a lower respiratory infection, wherein we know that it is a productive cough. It's a deep type of cough which is present. Breathlessness is key feature of lower respiratory infection. Respiratory movements could be slow if there is an underlying pleural effusion. So we ask the parents whether the child has cough which is dry, which is productive, whether he feels breathlessness any time of the day, whether the infection is causing undue respiratory distress in the child, whether child is irritable or hypoxemic. Next one. Yeah. Next one. Yes. So these are the normal respiratory tract anatomy, and we know that alveolar disease is pneumonia or bronchiolitis, which causes viral alveolar damage also, or interstitial lung disease. So these are classical disease which involves upper airway and lower airways, and we need to differentiate when we diagnose them and then start them treatment. Next one, please. Next one. Yeah, this is a diagram which shows, sorry, previous one, please, which shows how the influenza virus, which has got neuraminidase, the red dot, with the help of salicylic acid, attaches the host, start replicating by releasing of enzyme, and oseltamivir will act prevention of neuromyelitis activity, and then further replication. So it is important to mention that this oseltamivir should be started as early as possible, even though the tests are awaited, or if the parents are not interested in test or not affording for the test. And this is a next one, a diagram which mentions about the dosages which we use in OPD practice. Last time Dr. Mahendra Patel has very nicely summarized these dosages. Uh, After 12 months of age, if the child is less than 15 kg body mass, it is 30 milligram 2 times a day. So he has very nicely said 60, 90, 120, and then yeah, 150. So 30 mg twice a day for 5 to 7 days, usually 5 days. What about the prophylaxis? There has been a lot of talk about prophylaxis of uh, influenza disease, especially H1N1, wherein another contact which comes with the contact with this patient can be started at half the dose, but the duration is 10 days. So the duration is very important. The duration is though half, it is for 10 days. When the dose is double, it is 5 days, like 30 milligram 2 times a day. If the child is weighing between 15 to 23 kg of body weight, then the dose is 40 milligram 2 times a day for 5 days. So it is 90. So, but if it is prophylaxis, it is 45 milligram just once a day for 10 days. If the body weight is 23 to 40 kg of body weight, it is 60 mg twice a day. So total dose is 120. But if it is prophylaxis, it is 60 milligram a day. And we know that 1 ml of oseltamivir is 12.5 milligram. So accordingly, it will be say 2.5 ml, 3.75 ml, 5 ml and onwards. If it is more than 40 kg of body weight, it is 75 milligram 2 times a day. And if it is a prophylaxis, it is a 75 milligram OD for 10 days. What about infants? Infant, the dose is 3 mg per kg body weight 2 times a day. And if it is 3 mg per kg body mass per single times per day. Next, please. Yeah. So respiratory infection, as we know, the symptoms are very classical. Let us look at three common conditions. One is whooping cough, croup, and RSV. We know that respiratory syncytial virus will cause bronchiolitis, meaning it is a disease of a lower respiratory airways or bronchioles. Because of affection of bronchioles, there is breathlessness, or there could be haziness on chest X-ray, and the symptoms akin to pneumonia. Croup. Croup is also very classically seen when there is a upper airway infection. Croup is laryngo-tracheal bronchitis, meaning that the upper airway is predominantly involved because of either infection, food, allergen, or maybe some reaction, which cause sudden choking. The child will start feeling extremely breathlessness, is not able to cough so strongly because of the swollen upper respiratory infection. But if the child is distressed, a large, is not able to breathe properly, saturation is dropping, a possibility of croup has to be kept in mind. Rule out upper airway obstruction, treat them accordingly. Nebulizer, racemic, epinephrine, antihistaminic are the keystone of the therapy. Dexamethasone has gone excellent result because steroid is anti-inflammatory, anti-edematous. Because of start of steroid, immediately the response is evident and the child will get better of breathlessness. Whooping cough, fortunately because of extensive vaccination at government as well as private setup, whooping cough is almost not seen nowadays. Gone are the days when the whooping cough was so predominantly seen, but because the vaccination is rampant, almost all kids are vaccinated with DPT. The disease is less common, but again it is called as 100 days cough. The child will keep on coughing, coughing, coughing all time, almost for 3 4 months, and the diagnosis picked up by the bacteriology, and the treatment is very standard use of microlides for at least 2 weeks. So we know that the cases who are coming to us in OPDs are fitting into either of them or definitely viral infection of flu. Next, please. Next, please. Yeah. Here comes the real challenge. When we ask for test for H1N1, many times the parents are not affording to go for this further test. And if at all they are affording, we have to do the meticulously a proper nasal and a oropharyngeal swab has to be done properly. The swab has to be taken nicely. It has to be kept immediately into the transport thing and should be transported in the lab immediately for further workup. Next, please. Now let us look at another child who was a diagnosis of exclusion. 7-year-old child who came to us OPD for coughing for almost 2 weeks, 3 weeks. You name the antibiotic and he has received. He went to family physician 2 to 3 times, started with azithromycin, immediately changed to amoxiclavulinic acid, then shifted him to the highest spectrum of cephalosporins, cephakine and whatnot, and asked for multiple tests, including CBC, ESR, X-ray chest, typhoid, and everything. But there was no fever, but there was nothing much. CBC shows lymphocytosis, IgA was normal, and X-ray chest was normal impression. So we know that the child has no high amount of eosinophilia. It doesn't look to me as bronchitis or allergic cough, and there is just mild lymphocytosis. We know that there is some kind of viral infection which is going on or triggering on, but somehow no one even thought of looking at viral infection as option. So many times we see in OPD 3 set of 2 set, 4 set of antibiotics being changed. Uh, my teacher has given a final nice quote to me that if you change antibiotics 2 times, it is better you change the diagnosis. If it is a bacterial, he should have improved with 2 good set of antibiotics given for proper duration. But if the child doesn't improve with antibiotics, I think it is looking at something else. Either it is atypical bacteria, it could be viral, it could be mycobacterial, it could be something else. Next, please. Yes. So we ruled out other possible causes. There was no significant weight loss. There wasn't anything which is pointing towards any other infection. Child was playful, no respiratory distress, and stable and cough free. And he was started on again influenza fluvir, however very late, but somehow the child improved. So meaning is that we need to have some studies which shows how late we can start oseltamivir after the child present to us in OPD, because ideally is 48 to 72 hours, but sometimes they come very late. So are they going to be effective if we start at that time? It's going to be real challenge. Next one. Thank you. So basically, oseltamivir is a real wonderful molecule, extremely palatable. There is no problem regarding this. Uh, Palatability is not a question mark. Easily available, easy to use, extremely helpful if it is started in first 40 to 72 hours. The reactions, side effect to oseltamivir are very far and few, except few skin rash and nausea, vomiting. We have not seen much side effect with this medication, and it should be started at prescribed dose, appropriate period of time to get a best outcome. Now, Dr. Mahendra.
Thank you so
Dr.
much,
Mahendra
sir.
wants to add anything? Mahendra bhai.
Yeah.
Mahendra, bolo. Because Mahendra bhai has very good experience regarding most of this communicable disease. He is extremely expert and
No, this
most.
Flovir, Flovir, though I've been almost 10 years I've been using,
Okay.
and in fact, guidelines to be, but almost 8 to 10 years, say this thing, patients admitted, particularly in admitted patients,
Yes.
pneumonia and this thing, na, so many patients have started on this thing and have found good results. This
Yes.
thing,
Very well.
especially
Very
small children and this thing, and except X-ray pe few haziness and this thing. Otherwise,
correct.
other reports being normal and symptoms, and this thing is fitting into it.
Yes.
So, particularly in admitted patients, I've used a lot for many, and after that, I've been using in many OPD patients also,
Yeah, very good.
particularly small children. I don't wait. As you rightly said, the test is costly,
Yeah,
RT-PCR is costly.
correct.
So people don't do it except sometimes maybe in admission. So
Correct.
OPD cases, it's very difficult to ask for RT-PCR.
Yeah, every time we can't ask,
So,
every season.
so OPD basis, I use this thing
Postal time.
since many years I use.
Yes.
In
Thank you
fact,
so
the
much.
guidelines
Doctor.
guidelines also mention,
Yes,
and
yes.
in fact, Nelson textbook had also mentioned, though in immunocompromised and this thing, the risk is high,
Yes,
but almost 30 to 40% of mortality due to proven flu,
yes,
was in patients who didn't have any immunosuppressive or any chronic disease or anything. They were healthy human beings.
correct.
So when we say ki immunocompromised and this, they are high risk, but this study, which US study, 30 to 40% mortality in normal persons.
Correct, correct.
So we should not wait, I think, this thing.
Yeah.
Proper clinical judgment and judicious use should be done.
Empirical therapy,
Correct,
yes, yes. Whenever
correct,
we feel
correct, correct.
strongly suspicious, we should definitely start oseltamivir, get the best
Oseltamivir.
benefit.
Correct, correct.
Yes, Dr. Prashant. Yeah.
Thank you so much, doctors, for your insight.
Thank
It
you,
was
Dr.
lovely,
Prashant. Thank
getting
you, thank
a
you.
lot of insight. Dr. Mahendra, Dr. Murlidhar, you had a lot of
Thank you, sir.
insights. It gave me a little more clarity on influenza and its management. Ultimately, empiric management is most important in our country. Sometimes the treatment is more economical than the investigations.
Correct.
Right,
Yeah,
doctor.
yeah.
Thank you. Yeah, thank you so much, doctors. And
Thank
wish you
you,
a very
thank you.
pleasant afternoon. See you soon. Thank you.
Thank you, sir. Thank you.
Only one hello.
Yes,
हाँ,
sir.
बोलो, बोलो.
Yes, sir.
Just wanted to know, as a company,
Yes, sir.
can you make a smaller bottle sort of
I
for
will.
small children and this
I
thing?
will pass on your suggestion to marketing, sir. Certainly.
Yeah, yeah.
Yeah. Hmm? Thank you.
Okay. Thank you very
Thank
much.
you, sir.
Thank
Thank
you,
you.
Mahendra bhai. Thank you. Take care.
Thank
Take
you.
rest.
Yes, take
Thank
care,
you.
sir.
Thank you.
Yeah.
Thank you. Bye.
Thank
Bye.
you, Kopila. We're logging
Sorry.
out.
Yeah.
Thank you, sir.
Thank you.